Good afternoon, everyone. Madam Nomsa, I hope you hear us. Dr. Masina, are you able to hear us?
Yes, I'm able to get you. Thank you.
Okay, excellent. And thank you so much for agreeing to be with us at such short notice. So before we start today's session, we want to welcome everybody that has joined us from the various facilities. This is one of our extraordinary sessions of the run of 3. Last week, we had Professor Lloyd Mlenga, our Director, Infectious Diseases, Ministry of Health. We were talking about the surge capacity and management of COVID-19 in the context of the third wave. We also delved into issues around the SARS-CoV-2 variants. So he went into issues of the mutations and what are the consequences of these mutations. Of course, sometimes they have no consequences, but unfortunately, mutations can lead to negative consequences such as increased transmissibility. Some of these mutations can lead to vaccine escape. Some of these mutations can lead to increased disease severity. He talked about variants of interest and variants of concern. And of course, variants of concern are those that spread disease of global significance. He mentioned the variants, the alpha, the beta, the gamma, and the delta. And of special mention was that the gamma is the Brazil variant can have transmissibility of up to 97%. Of course, in wave 1, it was mostly the wild type of the virus. And when we had our second wave, it was actually mostly because of the beta variants. As for the second dose vaccine, the Ministry of Health has slated to start giving second dose of the COVID-19 vaccine on the 23rd of June. A special welcome, I've seen Dr. Agatha Lloyd. She's very key actually at LPHO in management of COVID-19 patients. I see that we've been joined by our colleagues from the facilities, and I'm hoping Dr. Mwemba can join, but I met him, he had an emergency. We hope Dr. Masuzio can also join us. That said, Dr. Masina, please go ahead with the presentation and you can introduce yourself. Do you want us to share the slide deck or you do it?
I think you can share the slides and then I'll just ask if we can move.
Okay. I hope everybody can see that. Okay, excellent. So I'm getting a thumbs up. I always make errors on this one. Dr. Masina, please introduce yourself.
Okay. My name is John Masina, and I'm one of the emergency medicine consultants at Levi Mwanawasa University Teaching Hospital. I've also been involved with management of COVID patients at Minor Soko Medical Center, and also part of the WHO consulted team and South Africa case management for COVID. So I've been both in Zambia and in South Africa for the last 8 to 9 months now. Yeah. So yeah, and then I was asked to present on the management of oxygenation. So I think I'm going to focus mainly on the key case management consideration for oxygen therapy in COVID-19 patients. So most of the therapeutics, I'm sure there should be another session where we'll talk about the therapeutics. And that will be the outline of my presentation. I'll give a few declarations and disclaimers, and then I'll go in and talk about just to outline the role of oxygen therapy in management of COVID-19 patients. Then after that, I'll describe the different modalities of oxygen delivery system. And then thirdly, I'll try to elaborate a little bit on the oxygen escalation and de-escalation protocols. Okay, next slide. Okay. So I just want to declare that I'm an employee of Ministry of Health Zambia. So most of the things that I'm going to say will just be in line with Ministry of Health, and that the information that I'm going to share in this presentation are evidence-based and some personal experience as a subject expert or just an expert opinion, because most of the things, I think, as we know, they are mostly just circling around expert opinions, and we don't have a lot of evidence for a lot of things that we are going to discuss when it comes to COVID. And then I also want to say I'm not representing the views of any government, and I'm not representing any institution, neither am I representing the organization that I work for. But only that I'm reflecting the views of my employer, which is the Ministry of Health Zambia. Thank you. Next slide. So I just want us to just have a brief pathophysiology discussion when it comes to COVID. And I think this is important when we start talking about oxygenation in COVID patients. So we need to understand that the first thing is that we do have the respiratory droplets containing SARS-CoV-2, which usually go in the respiratory system. We know it affects the nose, the mouth, the eyes, and that's why we've been putting on masks and we've been avoiding touching our faces, our nose. And then anyway, to this, it looks like a very busy diagram, but I can try to simplify it. So the first thing we should understand is that there is alveolar edema. So when the COVID goes to the lungs, it causes some form of edema. And then it also activates the inflammatory markers like interleukin-6 and interleukin-1, sometimes interleukin-4 as well, which leads to inflammation. And then when this inflammation sets in, it causes healing by secondary intention, which causes fibrosis. Okay, so once that fibrosis sets in, then that part of the lung does not participate in the ventilation oxygenation capacity of the alveoli. There is also bronchoconstriction because of the secretions that are produced, and these secretions lead to blockage of terminal bronchi. And then this leads now to the hypoxia that we see, which is just the low oxygen levels. I'll come to it later on in the presentation. When this hypoxia sets in, it brings in the shock, which is a septic shock. And then after that, it leads to mouth organ damage. Then after mouth organ damage, then we expect that there will be most likely death if it is not managed. And of course, we know that COVID affects every other system. So apart from the respiratory system, it also affects the cardiovascular system. It affects the neurovascular system. It affects the neural system. It also affects the hematological system. So when it affects the hematology, it affects the complementary system, which leads to platelet aggregation and clot formation. Under the complement system, that's where it also affects the platelet aggregation and clot formation and increase in the D dimers, which we see in our labs. Under the cardiovascular system, it will affect the heart muscles, which will lead to myocarditis, pericarditis. Sometimes it might lead to blockage of the coronary vessels, which leads to an acute myocardial infarction. Sometimes it might also cause pericardial effusion, but all these are just part of the effect that COVID can cause on the multi-organ system failure. Today, we are going to align ourselves mostly to the respiratory system. So what we talk about is just the alveolar edema, the bronchoconstriction, the blockage of the alveoli and the terminal bronchi leading to hypoxia. So I'll concentrate mostly on the management of this hypoxia that comes in as secondary to infection with COVID. Next slide, please. So I usually pause down and I give a poll question, which I think Dr. Foloshi can run. Over to you, Dr. Foloshi.
Thanks, Dr. Masina. So state whether this statement is true or false. Effective oxygen delivery systems should be a universal standard of care and should be made available widely. We'll allow that to go for some time. We have almost 400 connections and 80 votes. Let's not have voter apathy. So Dr. Masina will go through this at the end where we've highlighted the responses, but please feel free to poll. Is this statement true or false? Effective oxygen delivery systems should be a universal standard of care and should be made widely available. Okay, so when you allow people to vote long enough, you start seeing things. So this is exciting. I will share the results very soon, Dr. Masina. Okay, we have over 400 connections. Dr. Masina, this shows you how much we really want to learn about appropriate oxygen delivery. So we once again thank you. Effective oxygen delivery systems should be a universal standard of care and should be made widely available. Is this true or false? So I'm sharing the results, Dr. Masina. So,
all right, thank you so much. And I think we can go to the next slide so that we'll come back and discuss. Okay, so this statement was actually uttered by WHO in 2016, and it's absolutely true that effective oxygen delivery system should be made as a universal standard and should be made widely available. But what is disheartening is that we never had time to look at these things and try to implement what they meant. So we can go to the next slide. Yeah, and we've seen that COVID-19 has affected well over, and it has caused mortality in well over 3.7 million deaths around the world. And over 70% of all hospitalized patients are needing oxygen therapy. And this is very true, especially when it comes to this third wave. We've seen that over 40% of all these hospitalized patients are requiring huge amounts of oxygen, and not just the amounts of oxygen, but huge flows of oxygen that they require to supply this oxygen to these patients. So sometimes it's not just the amount of oxygen that you need, but also at what pressure you are giving this oxygen, and also at what flow are you giving this oxygen. And this is where it becomes very challenging. And then it is also important to have knowledge of oxygen delivery equipment and their use. And I think this is why we are here. So we just want to have a knowledge of how we are going to use them, regardless of the level of care that we have. And then we also want to learn about the management and monitoring of oxygen supply, which is very, very vital. So if we can learn how to manage this, how to monitor the oxygen supplies, and then maybe we might have a chance in terms of controlling this pandemic. Next slide, please. All right, so I just wanted to give a few studies that were showing that actually oxygen works in these patients, and we've seen how much oxygen that is being required everywhere around the world. The paper on the left top, I think it's a technical specifications of procurement of oxygen therapy and monitoring devices. It was a guideline produced by WHO. That should be, I think, June last year. So it was just giving the modalities of oxygen, the delivery devices that we should look at. They talked about the oxygen cylinders, they talked about the concentrators, they talked about the Venturi masks and the nasoprongs, which I think I'm going to talk about in our session today. And this really becomes very important because we need to understand how each and every one of them works for us to use them effectively and efficiently at our patient. And then on the left side bottom, I just put out a paper from South Africa that showed that oxygen therapy lifts the chances of survival in severe COVID. And this is true. And we've seen most of the severe COVIDs needing a lot of oxygen and needing a lot of pressure to deliver this oxygen. And we find that some of them, they pull through and they survive. And then the other side, I just went to e-clinical medicine, where I looked at a paper that looked at the utility of high flow nasal cannula for severe COVID-19 pneumonia in a resource-constrained setting, like our setup in Zambia. And this was a multi-center prospective study. So these are really good evidence to show that really oxygen works in COVID patients, and not just the amount of oxygen, but the flow at which you are giving the oxygen is also matters. And I'm going to elaborate more when we come to that. So next slide, please. And here I was just trying to give an overview of how much oxygen that we need in around the world. And you can see that there's been a shortage of oxygen everywhere. India had share a bit of problems, South Africa as well. We can talk about Zambia. Even at the moment, we're still having a shortage, and there's a lot of cry to how we are going to manage oxygen. And I think this is where the session comes in. Imagine at one point, India, I think on the paper, on the highlight on the bottom left here, it's showing that they needed up to 14 million metric tons of oxygen per day. That was during their peak of oxygen requirement. And all these countries that are in deep blue shade, they are the ones that need a lot of oxygen. Some of them were ranging between 3 million metric. Argentina at some point, Iran and Turkey, but I think I'll give an update on where we are. And then on the bottom right there, I was just trying to give a comic to say, okay, fine, we are going to change the nitrogen, the ammonia, all the cylinders, we're going to change them to oxygen, and maybe we might not have a shortage. Next slide, please. All right, so on this slide, I think I just wanted us to understand the oxygen system and what we need to have. So I've tried to label them. The first one, which is green there with a dummy on nasoprons. And this is what I think most of the lower level facilities should plan for. We need to see that we have nasoprons. We need to make sure that for all those piped oxygen facilities, they need to have raw oxygen, and that raw oxygen should have a flow meter that should regulate the flow at which they will give the oxygen, and that becomes very important. I'm going to talk about so flow meters and raw oxygen. And then the number 3 that I was talking about was the cylinders, and we've seen a lot of cry from all the other countries in terms of the cylinders, and also the connection to the cylinders, which are the flow meters, what nozzle goes into the cylinder, and all that. And then number 4, I wanted to illustrate the concentrators, the oxygen concentrators. So these ones become very handy when you're dealing with patients that need very low flow of oxygen, and those patients that are recovering. But in an acute phase, and those patients that need a lot of high flow oxygen, the cylinders really have no much help, but they really help in terms of the combination, the cylinder, in terms of the concentrators, they really don't have the help when it comes to acute phases. But usually you combine the cylinders and the concentrators. And then on the other side, on the right side, I just wanted to elaborate very small things that people usually take for granted, like number 6 and number 5. Those are the Venturi masks and the poly masks. And most of the time we forget about these things. Of what use is it going to be if we have a cylinder, we have a meter and the flow and everything, but if we don't have a poly mask or we don't have the Venturi mask, it will be very difficult for us to deliver oxygen to the patient. And that's why it is important to have your own monitoring system of all these devices, and also the reordering threshold. I'll come to talk about it when I come to give the policy guidelines on what we think each and every facility should do. And then here, I was trying to give now the high level management of patients when it comes to after the flow and all the FiO2. Now we think maybe we need to up the grade to higher level delivery modalities. So the first one there that looks like a military gadget, but it's actually not. It's just what we call the Cpap Mask. And then the next picture to read is just how it fits on the patient. And those are very, very important, because it becomes very important at some point during the illness that you might need to give them a little bit of pressure. And these masks become very, very handy. But these are for high level, like tertiary hospitals and central levels. And then I've also put on the right side there, I've put a high flow nasal cannula, or the whole machine. So there's a tubing, there's a control system, and then there's a pressure system that is created. And this gives oxygen at a pressure of even as high as 70 liters per minute. So you can titrate your oxygen from 40 liters per minute all the way to 70 liters per minute. So it gives very high pressures at some very high flows, and sometimes it might also give a little bit of pressure, like a PEEP of 3. And also it has an advantage that the patient will be breathing on their own. There's nothing clustering on their face like Cpap mask. And then on the left bottom here, I just wanted to give a picture of a ventilator, which might become very important as well, as we know, in about 2 to 5% of patients that might require mechanical ventilation. We can have a deep down discussion, but I'll ask, I think, Dr. Mwemba and Dr. Masuzio also to just jump in when it comes to mechanical ventilation and the other modalities of oxygen delivery. But I will elaborate more on the polymask, the nasal prawns, and the simple mask, because this is what I feel is very important for lower levels of care, like the district hospitals and the provincial hospitals. Next slide, please. On the next slide, I think I paused down and I gave another poll question. Over to you, Dr. Folosh.
Thank you so much, Dr. Masina. So intriguing. So the second poll question, clinical signs are not reliable indicators of hypoxemia. Clinical signs are not reliable indicators of hypoxemia. Is this statement true or false? Clinical signs are not reliable indicators of hypoxemia, meaning when you examine a patient, are you able to determine if they've got hypoxia from them looking and smiling at you? Then you say, oh, okay, likely this oxygen is fine. Clinical signs are not reliable indicators of hypoxemia. Is this statement true or false? We'll give it a few more seconds. Clinical signs are not reliable indicators of hypoxemia, true or false. So we'll give it 10 more seconds. We have almost 500 connections. At least we have voter turnout of more than 50%. So we'll end that and share the results with everybody else. I hope you can see that, Dr. Masina.
Yes, I can. This is really interesting. So we've got 35% that has polled for true, polled for false. And this is like one of my favorite poll questions when it comes to this session. Okay, let's go to the next slide. Okay, and this is why this slide is actually put here. Maybe we can just go to the pictures. Yes, this becomes very, very important. Honestly speaking, I have never seen a pathology that causes hypoxia so much in patients without any cardiovascular or neurological manifestations as compared to COVID. These patients will come in talking to you, walking in, smiling at you, the so-called happy hypoxia. And these patients, when you put the pulse oximeter, which is the gadget on the left side, and it will show that they are at 42. And this has never happened in any of the pathologies that we've come across that needs oxygen. You can talk about the heart failure patients, you can talk about the asthma patients, you can talk about the COPD patients. They all get confused when their saturation is less than 80, less than 70. Maybe the COPD patients can survive somewhere around 75, 80, but they will all get at least a neurological manifestation when the SATs are below 70. But in COVID, very surprisingly. And that's why as managers, as hospital administrators, as the Ministry of Health, trying to fight this COVID, we need to invest in the pulse oximeters, the two gadgets that we have shown there. We need to invest in the pulse oximeters. Every level of care should have at least a pulse oximeter. And then on the right side, I've shown the blood gas analyzer. This will be very important when it comes to high-level management of patients like centers and COVID ICUs and all the ICUs. So it becomes very, very important that, sorry, I think I must have paused a little bit there. But anyway, I was talking about the blood gas analyzer. I was trying to say we need to invest in the blood gas analyzers because these are going to make a difference when it comes to management of patients. These are the gadgets that are going to make a difference. Next slide, Dr. Foloshi. So clinical signs are not a reliable indicator of hypoxemia. And pulse oximeters should be available in all settings caring for patients with severe acute respiratory illness and used to measure pulse saturations. They should be at pre-hospital level, emergency area, wards, and ICU. And as managers, we need to make sure that these gadgets are in all these areas and they should be procured and distributed to all the hospitals that are managing COVID patients. And if we want all the hospitals to manage COVID patients, we need to have pulse oximeters at all levels. And these will become very important because you are not going to tell when the patient is dying. You are not going to tell when the patient's saturation needs oxygen supplementation. Blood gas analyzers can be available in ICU, that's fine, because they'll measure the pH, they'll measure the PCO2, they'll also give you other parameters like sodium and potassium and other electrolytes. But I think what is important is the wide distribution of the pulse oximeters, and this should be made as a priority to all facilities. And we know that hypoxemia is a measurement of partial pressure of oxygen in the arterial blood gas. The normal is supposed to be between 80 and 100 millimeters of mercury. But the pulse oximeter is a very good proxy that will give you just the percentage of oxygenated hemoglobin. And then we do have these parameters that come in like assessment indicators like the PF ratio, the Kigali modified ratio, and all these things will become very important only if we are able to do the blood gas analysis in the ICU. But what is important with the high impact of assessment is the pulse oximeters. And then, of course, we are not going to forget about evaluation of patients. Yes, it's important to examine the patient and get the history, but we need to have a pulse oximeter for us to assess completely at what level of hypoxia we are dealing with when it comes to COVID patients. So you need to look at the work of breathing for the patient, use of accessory muscles for breathing, the respiratory rate. Any respiratory rate above 25, above 30 is a clear indication that the patient is battling. And then vitals, of course, the blood pressure, the temperature, the saturations, as we've talked about. Another important vital is the GCS. Any alterations in the medical state or in the mental state of the patient is a form of severe disease, irrespective of their saturations. If a patient comes in confused and they've got COVID, it's already a sign of severe disease. However, the clinical signs should be, you have to take the history and examine your patient because this will guide you in an alternative diagnosis. A patient with a pneumothorax will come in with shortness of breath. And how you treat that pneumothorax is different from how you are going to treat a pure COVID without any pneumothorax. A patient with heart failure will also come in with shortness of breath, and they could be positive for COVID. So we don't need to forget about our usual history and examination of a patient. And I think that's what is very, very important. Okay. We can go to the next slide. Sorry, I think I must have been cut off again. But again, here I was just trying to say, when should we give supplementary oxygen? And this becomes very important. And when I come to the later stages in the presentation, I think I'm going to elaborate more. But I just wanted to give oxygen immediately to patients, either adult or children with severe respiratory distress, sepsis with hypotension or shock, altered mental status, like I said, or hypoxemia, measured either by a blood gas analysis or by a saturation probe. And always, if the patient is hemodynamically normal, your SATs of less than 90, you're going to start your oxygen. If the patient has any emergent sign, even if their SATs are above 94, 96, but if they've got increased work of breathing, they've got confusion, they are using accessory muscles, their respiratory rate is above 35, you need to start oxygen because the next thing is they'll tire out and they'll die. So you need to start oxygen early. And then for pregnant women, any saturation less than 90, you need to start them on oxygen, targeting your saturation between 92 and 95. Next slide, please. And then in pediatric population, I wish, and I think there are some pediatricians on the call. Dr. Manoj, I think, will be well vested to help us with anything that comes to children. So we try to use a few proxies that we want to see, like central cyanosis, nasal flaring, and in some certain conditions, we want to look at the severe lower chest indrawing, respiratory rate above 90, and head nodding, especially neonates. These will be signs that this patient will need oxygen immediately. Next slide. I wanted to pause a little bit again and just give Dr. Foloshi a chance to go through the poll question number 3. Over to you, Dr. Foloshi.
Thank you so much, Dr. Masina. Which one of the following gives the correct escalation therapy for oxygen delivery? Is it A, Cpap, HFNAC, which is high flow nasal cannula, non-rebreather mask, simple mask or nasal prongs? B, a simple mask, then you go to nasal prongs, then the NRB, non-rebreather mask, then HFNAC, then Cpap? Or is it nasal prongs, non-rebreather, a simple mask, Cpap, HFNAC? Or is it nasal prongs, simple mask, non-rebreather, HFNAC, then Cpap? Bit of a tongue twist there, but it's basically asking us, when we are escalating oxygen, where do you start and where is your upper limit? Which of the following gives the correct escalation therapy for oxygen delivery? What should you start with when you have a hypoxic patient? What is your lower end if you have low oxygen requirements? And as you escalate to high oxygen requirements, what should you give? Do you start with Cpap, then go to HFNAC, then non-rebreather mask, then a simple mask? Then when you are very sick, you start a nasal prong? Or do you start with a simple mask, a nasal prong, then non-rebreather mask, then high flow, and then Cpap? Or is it C, a nasal prong, non-rebreather mask, simple mask, Cpap, then HFNAC? Or is it nasal prong, simple mask, non-rebreather, HFNAC, Cpap? It's a bit much, but let's see what we think, because at this point in the pandemic, this is COVID-19 on steroids. It's not like we've won. All of us need to start getting familiar with these concepts. It's not only for our critical care, our emergency room doctors, not only for our pulmonologists, it's now for all of us. So we'll pause that. Very interesting voting pattern, Dr. Masina. Okay.
Yes.
So
all right. Let me just see. Okay, so we have like 63% going for D, and then we have about 27% going for B. Okay, cool. I'll come to that, and then let's go to the next slide. And this is, I think, one of the most important slides, because this now gives us the modality of oxygen delivery at different levels of care. So we have the primary health or district level care, and then we have the provincial hospitals or tertiary level care. Remember, when you are giving oxygen, oxygen is a drug. So it has a dosage and it has a duration. And every time you want to give this oxygen, you always have to think about this, that it has a dosage and it has the duration, and it is a drug. So I'm giving it to a patient, and it might have side effects as well. And of course, when it comes to this pandemic, we also have to think about the cost implications that it's going to have. So on the table, when it comes to primary healthcare stroke district level, we need to titrate our oxygen and use the appropriate dose and the delivery device. So both the appropriate dose and an appropriate delivery device. So if you have a patient that you've started on nasal prongs, the dosage on nasal prongs is between 1 to 5 liters per minute. At that point, you are delivering 0.25 FiO2 or 0.4 FiO2, which is 25% to 40%. And those are nasal prongs. If you go anywhere beyond 5, you go to 6, you go to 7, you go to 8, all you are doing is 1, you are wasting your oxygen, and then 2, you are also causing mucosal ulceration or mucosal drying in the patient and making the patient uncomfortable. So if you have a patient who is on nasoprawns, you are delivering oxygen at 5 liters per minute, and the patient is not improving, they are still confused, their saturations are still less than 90, or their respiratory rate is still above 40, or their use of accessory muscle, meaning their wake of breathing is still high, it means you have to change the modality to the next level. And your next level is a simple mask. So you start with your nasal prawns. If your nasal prawns are not working, you really need to re-examine these patients. The secret is re-examination of these patients. It's not that you give them the oxygen and that's it. You need to change, you need to re-examine. Every 1 hour, you come back and see the patient. How are they doing? Is their respiratory rate coming down? Is their wake of breathing coming down? Is their GCS improving? Is their hemodynamic status still remaining the same? If there's no change and they're still battling to breathe in on nasal prawns, you go on to a simple mask. Again, the simple mask, the dosage is between 6 liters per minute to 10 liters per minute. We are delivering an FiO2 of 0.4 to 0.6, which is 40 to 60%. And anytime you go beyond that with a simple mask, it means you're just wasting your oxygen and you are not improving anything on the patient. And remember, the commodity is very expensive. Our tanks are under pressure. So wasting of this resource becomes not a thing that we should even talk about. So we have to use appropriate doses and appropriate delivery methods. And then if they're not improving, looking at all these modalities, you move on to the next oxygen modality, which is now a non-rebreather mask or a mask with a reservoir mask. So now you give at 10 liters per minute to 15 liters per minute. You are delivering an FiO2 of 0.6 to 0.95 FiO2, or 60% to 95%. If the patient is not improving at this point, if you are at a tertiary or if you are at a primary level care or you're at a district level care, you need to start thinking of referring this patient to a provincial hospital or a tertiary care. And actually, what I would advise provincial health care or district level is that as soon as your patient crosses the line of a simple mask to a poly mask, always think about referring this patient. And I'll talk about how you're going to refer patients and what you should look out for when you're referring patients. So now we go to the provincial level hospitals or tertiary hospitals. All the modalities applied on the primary health care apply here. And here we allow you also to do what we call the double oxygen. I'll give Dr. Mwemba a minute or so at the end of the presentation, I think, to just elaborate how this thing works. But we combine a non-rebreather mask and the nasal prawns. I don't want the primary health care or district level hospitals to try this. And that's why it's not part of the primary health care. It's always at a tertiary level care. So we can use nasal prawns and we can use a non-rebreather. And then if that doesn't work, then we have to think about the high flow modalities. Under the high flow modalities, we've got the high flow nasal cannula, we've got the C-circuit, we've got the Auxilla mask, though it's not on the market yet, only experienced in South Africa. I'll give some elaborate towards the end in the discussion. And then we've got the non-invasive pressure ventilation, or the Cpap or the BiPAP. This is, we can have a discussion with the guys in ICU, we can have a discussion with the guys at provincial hospitals, but I think what is important is that you need to escalate at what level, and then you need to know what implication it will have. If you have 5 patients on high flow nasal cannula and you are sitting let's say we are sitting at minor Soko or Levy, then you know you are going to put a lot of pressure on your tank. So you need to understand where you are and you need to understand which modality you are using. And then, of course, the mechanical ventilation, which is either volume control or pressure control or APRV modes, which is also another discussion that we can have on another day. But these are the oxygen modality modes, and this is how you go about escalating them. One other thing that we need to think about is every time we are titrating oxygen, we need to target. So we are targeting saturations above 90 in adults, like we said, and saturation is above 92 to 95 in pregnant patients, and we're targeting saturations above 94 in adults or children with multi-organ failure, and all those with the immediate emergency signs of respiratory failure. Remember, titrate your oxygen up and down to achieve the targets, and always do not wean off oxygen when the patient, only wean off oxygen when the patient is stable. Do not wean off oxygen when the patient is unstable. Patients with confusion, patients with increased work of breathing, even if their saturations are above 96, don't wean off oxygen. I will elaborate a little bit more when I come into the clinical red flags. Next slide, please. Okay, so on this slide, next slide, Dr. Foloshi. On this slide, I was trying to give an initial oxygen therapy at all levels of care by first contact. I understand that sometimes doctors are not going to be around all the time. I also understand that the senior nurses and ICU nurses are not going to be around all the time. But it's very important for everyone that is in the ward to understand a little bit about oxygen delivery. So I deliberately put how the patient is going to present and what saturation levels. So a patient presents with saturations below 90 in room air. He has increased work of breathing with a respiratory rate above 30. That's the first box on top. With a neurologically stable GCS of 15-15, hemodynamically stable blood pressure, pulse, all within normal, and they are suspected or confirmed COVID. You need to start them on oxygen. So if the saturations are less than 85, start them on a non-rebreather mask and put that non-rebreather mask at 15 liters per minute until the doctor comes and sees the patient. If the saturations are between 85 and 90, start that patient immediately on a simple mask, put it at 10 liters per minute until the doctor comes to see that patient. If the saturations are above 90, but they've got increased work of breathing and everything else, start them on the nasoprons at 5 liters per minute until the patient is assessed by a doctor. This is very important. And this is, I think, what we should take and teach everyone, including cleaners, nurses, or junior nurses, and including porters. Because if they can do this before the doctor can see the patient, it will save a lot of lives. Because the moment you wait and say, no, the doctor is coming in the next 15 minutes, that patient won't be around. What is important is the box below to say, recheck the patient for improvement or deterioration. Check at least every after 30 minutes. You check for the saturations, you check for the work of breathing, you check for the neurological and hemodynamical stability, and also just if they are either improving or they are not improving, they are getting worse. And then I've put a few footnotes down there just to give a guidance on when the doctor comes in, what they should do. But this is very, very important, because if everyone learns this, we are going to have at least a sense to say, even if the doctor is not around, they know what to do initially at least. Next slide, please. I think next slide is just a repetition of the previous. So you can jump it because we've alluded to it. Okay, so next slide, Dr. Falosh. Okay, this is also another very important slide that I wanted us to put as a take home. So I just wanted to look at the infrastructure consideration and the policy guidelines, and this becomes very, very important. We all understand we've got infrastructural challenges, but we need to do something. So we do have space limitations. Overcrowding has become a really big issue. And this is called what we call the exit block in emergency medicine. So patients are crowding in the emergency department. So if we can capacitate the clinics and the down referral hospitals to take care of patients, maybe those patients that need less oxygen can be taken there. And then access to space as well. The triage system, we need proper triage system. We need physical distancing in our hospitals. So all these visitors and everything, I think, should be taken out. And then hand hygiene places and the facilities should also be implemented. And then health facility design has also been a problem. They are not suitable to handle infectious diseases. Interdepartmental movement of patients also becomes a challenge. A patient who is intubated in the emergency department will become a big challenge to take to ICU. And then portable oxygen as well, we don't have. So we need to plan for this, either a small portable oxygen or a big oxygen cylinder that needs to move patients. This becomes very important, especially with Dr. Siska, who is involved in movement of patients from one facility to the next. I think they need to plan for this, and also portable equipment for diagnosis and treatment. It becomes very important. Movement of patients to X-ray department, and all that becomes really, really challenging. So we need to think about that and plan around that. But the guidance is that all facilities should have a designated screening area, and they should have updated screening tools with risk assessment tools, which are locally formulated. And I'll give a little bit of guidance on what red flags we should put on these screening assessment tools. And then all facilities should have some form of isolation room or ward for suspected and confirmed cases. This has become very important, especially with strict adherence to IPC measures. All healthcare workers to adhere to IPC measures and protect themselves at all times. And N95 is needed at all times if you're treating patients in a COVID ward. And then all facilities should plan for oxygen delivery equipment and formulate a localized monitoring capacity for both consumables and PPEs. This can't go without an emphasis. We need to have a plan for reordering levels. We can't sit and say we don't have polymasks. We should have planned before we have a patient in front of us. And we need to understand individual facility limitations. If you breach that individual facility limitations, you need to start thinking about referring the patient. We need to talk about referral systems. We need to agree how we are going to transfer patients, and we need to agree to which facility the patients will be transferred. This can be at the provincial level, or can be at the district level, or can be at the facility level as well. We need pre-arranged referral system agreement, and then timely and well-coordinated referrals. And this is what I'm coming to. Risk identification. Which patient should I refer? Why am I referring this patient? I think I'll come in when I come to talk about how to refer. And then treatment initiation at lowest level of care. This becomes very important. We need to talk about treatment initiation at lowest level, and enough portable oxygen when you are moving these patients. Adequate communication to a receiving facility becomes very, very important. So people should have this sense of trying to anticipate problem rather than trying to sort out the problems that we have. And then here we just wanted to give next slide, Dr. Foloshi. We just wanted to give an overview or just an highlight of what we have in terms of the oxygen capacity. You can see how many hospital beds we have. You can see how many standard beds we have. You can see what our capacity is when it comes to Lusaka facilities and also Copperbelt. Sorry to say that these slides are like 2 weeks old, and I'm sure most of the information on these slides have actually been updated. But what I want us to focus on is the number of high flow nasal cannulas and the number of oxygen concentrators that each facility has. Because I know the standard bed spaces and the ICU bed spaces will change as the pandemic rolls over. And then the next slide also is just giving the same information, but in the other modalities. Look at Northern Province, look at Luapula, and also Northwestern, where we have like 0 number of high flow nasal cannulas. And these are the provinces maybe that should be thinking of referring most of their patients that need high flow oxygen way early and quite in time. Otherwise, we are going to encounter mortalities along the way. Okay, so I think those were like long slides. And then I wanted to pause and let me hand over to Dr. Foloshi again for a poll question number 4. Over to you, Dr. Foloshi.
Thank you so much, Dr. Masina. That's very useful information. The 4th poll question: in the treatment of COVID-19 patients on oxygen, which of the following will you consider changing as you escalate the oxygen therapy? Is it A, the flow of the oxygen, B, the FiO2, which is the partial pressure of oxygen in inspired air, C, the PEEP, or that is the pressure, or are you going to give pressure support, or all of the above? When you're escalating oxygen for patients in your facility, which of the following will you consider in terms of escalation? What can you escalate? So is it A, the flow of oxygen, B, the partial pressure of oxygen in inspired air, which we call the FiO2? Is it only the pressure, which is the PEEP or pressure support? Or is it all of the above? This is interesting. It's good that we now all have, it's all hands on deck. So please feel free to vote. Dr. Masina will go through the responses. In the treatment of COVID-19 patients on oxygen, which of the following will you consider changing as you escalate the oxygen therapy? Is it A, the flow of oxygen, B, the partial pressure of oxygen in inspired air, the FiO2, C, is it the pressure, all of the above? So we have about 46% voter turnout. We have over 580 connections, which is good. Please let's all attempt to vote. With oxygen therapy, we've had a lot of junior doctors helping us in this. We learned this pretty quickly. It can appear scary, but with time, you learn that it's very easy to understand escalation and de-escalation of therapy. So we'll end this poll now and share those results with the network. Okay, our internet is a bit slow, but this is the voting pattern.
Yeah, that's very good. So we do have like 80% saying all of the above, and then about 12% and 7% saying either the flow or the FiO2, and the pressure only about 2%. That's good. So we can go to the next slide. And this is very, very important to understand. So COVID-19 patients would need a change in all the three parameters of oxygen delivery: the change in the flow, the change in the FiO2, and the change in the pressure at the later stage of their treatment. And that's this on the left side. I think I just pulled out one of the papers that came out in January 2021. I think it was in the Pulmonology journal. So they were talking about non-invasive respiratory support path in hospital patients with COVID-19, and they proposed an algorithm, and that's the algorithm that they proposed, the one that I've put below there. Looks very complicated, but honestly speaking, I think what we should do is we should always ask ourselves, what do I want to change when considering escalating the delivery of oxygen? Do I want to change the flow, or do I want to change the FiO2, or do I want to change the pressure? Or if I'm moving from one oxygen delivery to the next oxygen delivery, what have I changed? You need to understand that you need to change something. You can't move from FiO2 of you can't move from FiO2 of 60 and then you go back to the FiO2 of 40. It means you're doing a disservice. These patients will need both the FiO2 and they will need the flow. And that's why when you're moving from nasal prawns to a simple mask, you are increasing the flow. So from 5 liters to 10 liters. And you are increasing the FiO2 from 0.4, which is 40%, to 60%. And then if you're moving from a simple mask to a polymask, you've already increased your FiO2 from 0.6 to 0.95, and you've increased your flow from 10 liters to 15 liters. And every time you jump from the polymask to the pressure modalities, you've increased the flow. So FNAC will give you a flow of up to 70, but it won't increase the FiO2. And then when you go to Cpap, the Cpap will increase your pressure, your PEEP, and your pressure support. So every time you're thinking about these patients, think about what you want to change. Are you changing the flow? Are you changing the FiO2? And at lower levels of care, all I'm interested in is change the flow and change the FiO2. When it comes to higher levels of care, please be mindful and change the pressure, because you've already reached the maximum of the FiO2. Now you have to change the pressure and you have to change the flow. That's why a high flow nasal cannula becomes important, and that's why the C-circuit becomes important, because it gives that extra PEEP, and that's why the Cpap becomes important, because it gives that extra PEEP and extra pressure. Early identifications of patients and early treatment is the key. Patient involvement and clear elaboration of treatment plans to the patient and the caregivers are very, very vital. This is what we are calling shared decision-making between the doctor and the patient. You need to explain to them. The patient, you are failing on the polymask. Now what we need to do is we need to add a little bit of pressure to you. We are going to put you on this machine. It will be pushing you and pulling you. Don't worry, it's what it does. The moment you explain to these patients, you elaborate nicely and give clear instructions, the patient will understand and they will probably be able to tolerate. And that's what we need to do. And they can come up with all these algorithms and everything, but an individualized algorithms at a local level is what we need. And these things should be stuck in the wall and everyone should know about them, including the junior doctors. Next slide, Dr. Folosh. And then I paused a little bit again and wanted to give Dr. Foloshi a chance on the poll question number 5. I think this should be the last poll question.
Dr. Masina, this is some very elaborate explanations, so we really appreciate. So which of the following is a clear indication of de-escalation of oxygen therapy in patients with COVID-19? Is it A, improvement in the Glasgow Coma Scale, so in general, the augmentation, okay? B, reduction in the respiratory rate and the work of breathing. C, improvement in the saturations and hemodynamic status of the patient. D, reduction in the D-dimers. E, A, B, and C above. So what should you look for when you are de-escalating? When should you say, oh, this patient is now getting fit for us to reduce the amount of oxygen we are giving, whether it's more pressure, more oxygen? Which of the following is a clear indication for us to start reducing the oxygen therapy in patients with COVID-19? Is it A, when the augmentation starts improving, also known as Glasgow Coma Scale? Is it B, when the work of breathing starts reducing and their respiratory rate reduces, they are not tachypneic anymore? Or is it C, improvement in the saturation, that is, you are checking on your pulse oximeter and hemodynamic status of the patient? D, reduction in the D-dimers, okay, a fibrinogen degradation product? Or is it A, B, and C above? This is exciting. We have very high voter turnout, Dr. Masina. This is a sign of commitment from our healthcare workers to managing this patient. So we are glad that you are demonopolizing knowledge and sharing it with the rest of us. So,
yeah, and I think that is needed, yes. Yeah, but I think this is also another very important poll question, and what we do really matters, because this is where now we start now talking about the patient themselves. So let's see how the voter turnout is, and it's really good. So 90% of the participants are saying A, B, and C is the correct answer. About 7% feel just an improvement in the saturation is good enough. In the saturations and the hemodynamics are good enough. So let's see what the notes are saying. Next slide. So really, when it comes to de-escalation of patients, it's never a one-size-fits-all. And this becomes very, very important, because the treating physician is the best person to know when to de-escalate and what to do. You can't walk into a COVID ward seeing the patients for the first time and you want to change everything. No matter how senior you are, it's not going to happen. The people that have been seeing patients over and over are the best guys that are going to tell you what we are going to do, where we are coming from, and where we are going. He was doing well at first, but then he just started drifting in and out of health coverage. I don't know what health coverage is, but this guy was drifting in. His GCS was going down. His saturations were going down. I don't know whether they were doing the right thing or the wrong thing. But be mindful of psychological effects on some of the patients, especially when it comes to COVID. Some of the patients will be scared. The moment you tell them, I'm going to bring down your oxygen, they'll tell you, doctor, no. Please don't, because they don't want to go back to where they were. So a holistic approach of trying to manage this patient, especially when it comes to de-escalation, is the best thing. Give them time, know your patients. The principles in COVID-19 is give time to recover. Just as there is time for the lung to be affected, there should be time to recover. And then when it comes to this issue they are calling post-acute sequelae of COVID, it has also just complicated everything, because some of these patients will need oxygen for a longer period of time. Some of them have reported up to 6 weeks. Some of them have reported up to 6 months after COVID. So you really need to be very, very careful on how you de-escalate them. Look for improvement in the parameters like the work of breathing, the respiratory rate, the saturations, the GCS, the hemodynamic, and the labs. But remember, radiology sometimes can actually worsen. So chest X-ray on day 4 and chest X-ray on day 8, you're going to see like it's 2 different X-rays from 2 different people, because one of them might even be very, very worse. But the principles are that start by reducing the pressure. When you reduce the pressure, then you can follow up by reducing the flow. And then when you reduce the flow, you can now follow up by reducing the FiO2. Remember, when we were escalating them starting with the FiO2, then we go to the flow, then we go to the pressure. But when we are de-escalating them, we want to wean off the pressure first. The issue here is that you want to wean them off all the way to something that they can stay without real, without any problem, like at a tertiary, at a district hospitals. So wean them down to a level of a tertiary hospital so that you can even let them go out. So you can even actually, you call it a step down referral. But a combination of reducing pressure and FiO2 simultaneously is acceptable. However, careful titration is needed, and this should be done by a senior personnel. You can talk to someone senior, you can call Dr. Mwemba, you can call the anesthetist, Dr. Spuka and Dr. Mateo, and try to discuss your patients. But the biggest challenge is that these people don't know the patient. So you need to explain to them very well what you're doing so that they understand very well, and then they will give you a proper expert opinion. But I think the best way is you should know your patients. And if you are lost and no one is picking up their phone because everyone is busy, try to wean off the pressure first, then followed by the flow, then followed by the FiO2. Okay, next slide. This I think should be my second slide. Next slide, Dr. Faloshi. Here, I just wanted to give a little bit of guidance when it comes to when to refer and how to refer. I've already talked about the clinical red flags, and I think all the presentation has just been about clinical red flags. Increased work of breathing, use of accessory muscles, and deep, slow breathing like gasping. That's a proper red flag to you. You don't have to sit with that patient. Put him on oxygen, the maximum that you have, and make that phone call to refer the patient. A respiratory rate, a heart rate above 120 per minute, despite their saturation, despite their GCS, maybe they could have a chest pain. You need to start thinking about referring this patient. That's a red flag. Respiratory rate above 30, it's always a red flag, despite the saturation levels. And altered mental status, we've talked about it. Elevated initial blood sugars, that's also another red flag. And any presence of comorbidities. These are like clinical. And then I've deliberately put labs and radiology in small letters because I don't want people to emphasize on the labs. High D dimers, chest X-ray with massive infiltration, CT scans with chest with ground glass appearance. All these have got grading systems. The CT have got grading systems where they talk about percentages, 60% involvement, 70% involvement. I think they divide the chest into 4, and then each quadrant is given 25%. If you have more than 50% involvement of the chest, that's severe, despite what the SATs are, despite what the patient is. If you have a CT scan and it has 50%, more than 50% involvement of ground glass appearance on the CT, that's severe. If you have an X-ray with massive infiltrates, that's already severe. But don't rely on the labs because these can only appear very, very late. What is important is the first clinical red flags. And this I want to take to all the facilities because it becomes very, very difficult for them to say you can go home for home isolation, come back later. This has caused us a lot of problems. Most of the patients are going home on home isolation and then they come back later as BIDs. We need to make a checklist and give to all facilities. Check for the work of breathing, check for the heart rate, check for the respiratory rate, check for the GCS, elevated blood sugars, we need to invest in glucometers at all levels so that we can check the initial blood sugars and also check for any comorbidities. If anything of these is deranged, that patient has to stay, whether at your facility or at home-based care with a follow-up. That follow-up can either be telephonic follow-up or can be physical follow-up by a community health care worker. And I think we've done this before. But what is important, I think, is us to scrutinize each and every positive patient at whatever level we are at. And then how to refer. And this becomes very important. And I'm sure Dr. Msiska has a presentation, I think, in the coming few days. At primary health care level, a maximum level of oxygen is a non-rebreather, nothing more. You can't do double combination at primary health care because you are running into problems. Once you fail on that, the patient is going to deteriorate and you're not going to have any backup. Patient needs a scored risk according to red flags. You need to score them so that you know whether they are improving that day or they are going down. And every time you're seeing this patient, this is what you should be doing. You should be scoring the risk assessment score at all times. What are the red flags? What can I see? And then treatment has to be initiated. Oxygen and sugar control, at least at the minimum level. You can start your oxygen, you can start your sliding scale of sugar as the patient is on the way. And I'm going to emphasize the pre-arranged referral with proper prior communication to the receiving center with the numbers of the referring and the receiving doctors given to the ambulance crew so that they know where they are going, they know who they are going to see. Make sure there's enough oxygen before starting off. All the time in emergency medicine, we always want a backup system. The backup system in terms of drugs, the backup systems in terms of oxygen, and the personnel as well. I always, like me, my practice is always that I will inform someone. Dr. Mwemba's phone always rings. Dr. Mwemba, I've got a patient like this and this and this. I'm very worried. If things happen, this is how we are going to go. Okay, fine. Continue treating. Let me know if there's something. That's a backup for you. He knows about the patient. Next time you call him and you tell him the patient has deteriorated, can I transfer? He's not going to refuse because he already knows. He knows about the patient. He's been following that patient with you from time to time. Always have this habit of having a personnel backup in terms of COVID, oxygen backup, in terms of drugs, drug backup as well. All right, next slide, Dr. Foloshi. Dr. Foloshi, yeah, so please consider being vaccinated. The safest and most effective vaccine is the one that gets into your arm first. No names involved. Whatever vaccine gets into your arm first is the safest. Thank you very much for your attention and feel free to ask questions. And over to you, Dr. Foloshi. And I've got a good team on the panel. I think they are going to attend to most of the questions. Thank you so much. And over to you, Dr. Foloshi.
Hi, Dr. Masina. Thank you so much for that presentation and that nice ending. For sure, I know I've seen a few of the panelists, so we will take a few questions from our network before we wind up with our poll questions. I know we will need another oxygen session because our current situation is that we are quite overwhelmed and most of our facilities are beginning to manage these patients. So this support you are giving is extremely important, Dr. Masina, and we appreciate it. So there are some questions, and of course, a lot of thanks to you in the chat boxes. We can unmute the participants who raised their hands. Somebody has a question, please go ahead and unmute.
Hello, good afternoon.
Good afternoon.
Good afternoon.
Hello, go ahead, please.
Yes, first and foremost, I must congratulate the presenter. He has really given us a very, very good presentation. Now I know the oxygen use in COVID patients. even if I'm operating from an outpatient. Now, my question is, we're talking about hemodynamically unstable patients. So the anemia comes in. It's very, very difficult to say whether the patient is desaturating because of respiratory or is it because of the anemia. So at what level would you say for instance, if somebody has HP of 7.5 and they are stable, what would be the safe oxygen saturation level?
Thank you so much, Dr. Kasonde. We will take the other questions so that we manage our time. Then you can answer that, Dr. Masina. Johnson Matola, please go ahead and unmute yourself. So that
Thank you very much. I hope I'm loud enough.
You are very loud, so it's perfect.
Okay, thank you. Dr. Masina had mentioned the Oximeters mask that I think he said to have been used mostly in South Africa. I wanted to find out more details about it, and in comparison to the C-Circuit, what is the difference and what are the advantages of that particular mask?
Thank you so much, John. We'll allow Michael Mwanza to ask their question. Michael Mwanza. Okay, Michael may not be available. Ida Zulu. Ida Zulu, please go ahead. Ida Zulu, are you able to unmute them? Okay.
Yes,
Ida?
thank you very much, Doc. Dr. Foloshi, thank you very much.
No
thank
problem,
you very
Ida.
much, Dr. Masina, for the presentation. Doctor, I'm also happy that we've gone through this oxygen management of COVID patients. But my worry is we are receiving patients in the facilities in a more stable condition. And right now, we are even seeing the parameters which Doc was actually mentioning. But because of the space where patients are being managed, because our patients are being managed like in OPD, they're in the inpatient, they're in the labor ward. So I do not know how effective this management can be, where we have got patients like all over where they are not in the same place. And also like the mentorship on the oxygen escalation that Doc has just mentioned. It may be more prudent if maybe we had, so I don't know from the team how you're going to do capacity building for the facilities on the lower level. What is your program, Doc? What is your plan to capacitate and look at what is happening on the ground? Because if patients are actually coming better and they're desaturating, we are losing them in the facilities. I submit.
Thank you so much, Ida. We'll allow Alex. Alex, please go ahead with your question. Alex,
hello,
please go ahead. Yes, Alex.
Okay, thank you, Dr.
You may need to move closer to your mic.
Okay, thank you for the presentation and thank you for the opportunity. Yeah, mine is not a question per se, but a plea. And that is concerning the referral system that is currently in use in the management of COVID. And I think there are a lot of loopholes, but there are a lot of walk-ins in the facilities, and there's no a straight line of who to go when you are feeling sick, where to go. Patients are going anywhere in any facility that is near to them, and I think that is putting a burden on certain facilities that and we have a clear referral system that allows the patient is feeling like this and to go to such a facility. I think it will help us in the management, effective management of COVID, and allow patients to be going anywhere that is from that. Thank you for coming.
Thank you so much, Alex, for that contribution. You can now mute your mic. I think the relevant stakeholders have noted this. It's a big issue everywhere, even for big hospitals like Levy and UTH. We are having people walking in, but it's quite understandable. it's quite a mentally traumatizing disease. So you sort of want to see a healthcare worker. So we may need to start empowering our patients. So Dr. Masina, do you want to pick up a few of those questions? Then I'll let Dr. Msiska pick up on the mentorship and capacity building. Dr. Masina?
Yes, thank you so much, Dr. Foloshi. And yeah, I actually wanted to suggest that Dr. Msiska picks up the mentorship. I think it's important and highly important. So I'm sure she's going to allude to that. Let me answer the anemia question, and then I'll answer the Oximeters mask as well. You know, these things I think come back in life. So in a patient with an HB of 7.5 or less, and you are thinking maybe the desaturation is secondary to the anemia, or maybe your level of saturations, or you are battling to ventilate a patient with anemia, or even in septic patients with a normal, maybe a HB of 10, but you are battling to ventilate them. The goal there is actually to transfuse them if you can, because you need to sort out where the problem is. Giving as much oxygen as you can is not going to sort out the problem. The underlying pathology is the low hemoglobin concentration. Actually, if you think about critically, you're going to find that patients that come in with a low HB, they actually present with saturations of 100%. Remember, your SATS probe is just measuring the percentage of oxygenated versus deoxygenated hemoglobin. So in a low state of HB, the saturations will actually won't be affected. They'll actually tell you 100%, but the patient is still battling. So the best way is in patients with low HB, sort out the primary pathology, which is their low HB. And that's very, very key. And your saturation levels will actually not be a reliable indicator, because they will actually present with high saturations despite them having hemodynamic or respiratory compromise. So I think that's a way to go with the anemic patients. And then when it comes to Oximeters mask, same principles. The only difference between the Oximeters mask and the C-circuit is that the Oximeters mask performs better at a lower flow. So it will give you a high PEEP of up to 20. You can titrate between 5 and 20, but it can produce that PEEP at a flow of 15 liters per minute. So you can use it with a cylinder. You can also use it with some of the oxygen concentrators. When it comes to a C-circuit, you need a higher flow. So the C-circuit will need a flow of somewhere around 40, somewhere around 60. But with the Oximeters mask, it will need a lower flow, but it will give you a good enough PEEP. The only thing is this mask is still under investigation. South Africa, it was produced in Eastern Cape in South Africa, and it has been marketed there. Some have gone to Malawi, Zimbabwe, Mozambique, and I think Botswana have procured some of them. WHO is trying to come up with a multi-center study to see their efficacy, and also to see what they are calling a non-inferiority study. So they want to compare them with the polymask and see how they perform, and then also compare them with a Cpap and see how they perform. So without all those evidences, it's very difficult for us to say, yes, you can use them and 100%, but we are waiting for studies to come out. But I think it's a promising mask, especially that it's using low flow with giving a PEEP at least. So it looks like promising. So let's keep our fingers crossed and see how this will come up. Thank you so much. Over to you, Dr. Foloshi.
So much, Dr. Masina. There's a lot, and there's some feedback that people can look up in the chat box, because we actually are only 4 minutes away from winding up this super, super important session. Dr. Msiska, there's been a request from Ida, and I think it's valid, where she says, are we looking into mentorship and capacity building? It's one thing to tell people what to do, but that side by side, escalation of oxygen, because as I mentioned, we are in a critical situation now. Dr. Msiska, any plans for this?
Thank you very much, Dr. Foloshi, and thank you, Dr. Masina, for that wonderful presentation. Yes, we're looking into it, and actually some facilities have already started asking for for some mentorship with our expert teams. We're working on that. So we should be in touch with the facilities that have already requested, like Chawama has already requested, and Matero. So we'll see how we can also factor in the other facilities. And some of them, some of the lessons will be via Zoom as well. Thank you.
Thank you so much, Dr. Siska and Dr. Masina. Thank you so much. We are now expecting facilities to be able to give oxygen. It means that they'll need cylinders. I know Levy easily, because looking at the number of high flow nasal cannulas that are used there, Cpaps easily can consume 100 cylinders, and that's the 50J per day. So it really has a lot of implications, but I think we need to keep moving. And I must say, thank you so much, Dr. Masina. We can see a lot of people have shown interest, meaning people are committed to this. So on our side as Ministry of Health, our IPs, our funders, we need to support the facilities to actually provide this service. It's one step at a time. So we have a few polls. Dr. Masina, do you want to quickly run through the answers to your polls? I know we have a lot of comments, and I want to thank our virtual panelists that are answering all those questions. We really appreciate. Dr. Masina, the polls.
Yes, please. Thank you so much. We can go back to, if you want, you can beam them through.
Okay, yes.
All right.
I will not relaunch them in the interest of time, but we can go through the answers.
We can just go through the answers at the end, yes. So you can just go right at the end. Yeah, you can go ahead right at the end of the presentation. Yes. So poll question number 1, it was true. This effective oxygen delivery system should be a universal standard and of care and should be made widely available. And this statement was uttered by WHO in 2016. And maybe we should have put more emphasis in putting this as a real universal standard and widely available. Next one, poll question number 2. Clinical signs are not a reliable indicator of hypoxemia. This has become very true when it comes to COVID patients. We've seen COVID patients that come in with stats of 42, but they look hemodynamically stable, neurologically stable. That's why it's important for us to invest in pulse oximeters and blood gas analyzers so that we can correctly assess the levels of hypoxemia in these patients and also the levels of tissue hypoxia in these patients. And then poll question number 3, which of the following gives the correct escalation therapy for oxygen? Yes, we need to start with the nasal prongs, then we go to simple mask, then we go to non-rebreather mask, then we go to high flow, and then we go to CPAP. Remember, you are changing the flow, you are changing the FiO2, you are also changing the pressure. So at whatever level you are moving at, you need to make sure all these 3 modalities are taken care of, either the FiO2, the flow, or the pressure is changed as you escalate the management of these patients. Poll question number 4, in the treatment of COVID-19 patients on oxygen, which of the following will you consider changing as you escalate the oxygen therapy? I've just given the answer to this one. So all the above, you change the flow, you change the FiO2, you also change the pressure. Poll question number 5, which of the following is a clear indication of de-escalation of oxygen therapy in a COVID-19 patient? The answer is E. You need to see the improvement in the clinical scenario. D-dimers can be low, but the patient is still sick. And that's why D was not included. And remember, not all the facilities are going to do D-dimers. So we want to be as clinical as possible and as practical as we can. So the D-dimers, yes, they're very good to be done, whether they are going down or they are going up, but for tertiary levels, and of course, they're not going to be indicative. If the D-dimers are 0, but the patient is still sick clinically, then don't de-escalate the patient. And then I also want to thank Jonas and Dr. Zacharia, I think from CDC. They've been answering most of the questions on the chats, and thank you very much. And most of the answers they've been given are really, really appropriate. Thank you so much, and over to you, Dr. Foloshi. Thank you.
Thank you so much, Dr. Masina. You have a lot of kudos here, so I'm forced to give up my diamond star. So you get our diamond star for one, being very responsive and supporting your country in this big fight. I know Dr. Masina is an emergency medicine consultant, actually, and you ended your presentation very well by showing a picture of yourself being vaccinated. And then I saw there were a lot of questions on vaccines that Dr. Zachary and Dr. Hines answered. And thank you for giving us a heads up on this Oximeters mask. It sounds like this is something that would be very useful in our setting. So we'll be looking forward to seeing the results. I hope Zambia will be one of the centers they use this on. I hope we are selected as the site, because I think this would be appropriate. Dr. Msiska, thank you so much for highlighting the issues around clinical mentorship, and we look forward to having capacity built in our facilities. So tomorrow there will be a session where we'll be talking about home-based care. I know there was a session on where you should have a pulse oximeter, and at the rate we are going, even the home may be a useful place to have a pulse oximeter, especially for our people that are on home-based care. As Dr. Masina has taught us, clinical signs are not enough. So someone can be happy and smiley, but you find that they're actually saturating at 35%, which is not a good thing. So thank you all for joining us, and we'll see you tomorrow at 12 for the session on how to manage patients in the outpatient setting and home-based care. Lusaka has done a bit of work around this, and they'll be sharing their experience. With that said, thank you so much. I've noted a lot of people are requesting for this slide deck, and rightfully so. So you can hang back as our IT explain how they'll get the slides to you. Thank you.
Dear network, so to access today's PowerPoint presentation and video recording, I have shared the link in the chat box. Kindly click on the link and then you can sign up to join Slack. Thank you. If you have any challenges, you can always let us know.
Okay, so we'll leave it open for some time, so
yes.
people can. Yes. And of course, I know Dr. Msiska is very good at this. She'll share this presentation on a lot